Hi, I'm Carla Angelica Pasmay Cottom. I'm going to talk about Caplacizumab for acquired thrombotic thrombocytopenic purpura. Definition: acquired thrombotic thrombocytopenic purpura, or ATTP, is caused by aggregation of platelets on ultra-large von Willebrand factor multimers. This microvascular thrombosis causes multi-organ ischemia with potentially life-threatening complications. Daily plasma exchange and immunosuppressive therapy induce remission, but mortality and morbidity due to microthrombosis remain high.
Acquired thrombotic thrombocytopenic purpura, or ATTP, is a rare, life-threatening autoimmune blood clotting disorder. During the normal blood clotting process, the plasma protein von Willebrand factor is important in recruiting blood clotting cells, also called platelets, to damaged vessels to seal the injury and stop the bleeding. In healthy individuals, von Willebrand factor is immediately cut up into smaller pieces by an enzyme called ADAMTS13 to prevent spontaneous recruitment of platelets when blood vessels are not damaged. However, in ATTP patients, antibodies that block ADAMTS13 from working properly are present. This results in an accumulation of ultra-large von Willebrand factor molecules which will bind to blood platelets and cause excessive formation of blood clots. The formation of these blood clots in small blood vessels throughout the body leads to a severe reduction in platelets, also called thrombocytopenia, a further breakdown of red blood cells referred to as hemolytic anemia, and an insufficient blood supply to tissue, also known as tissue ischemia. This results in organ dysfunction, commonly involving the brain, heart, and kidneys, and may cause acute thromboembolic events such as stroke and heart attack. Despite the current standard of care, ATTP patients remain at risk for significant morbidity and mortality.
Trombotic thrombocytopenic purpura, or TTP, belongs to a group of blood disorders known as thrombotic microangiopathies, TMAs. TMAs are characterized by clotting in small blood vessels, a reduction in platelets, or thrombocytopenia, the destruction of red blood cells, referred to as microangiopathic hemolytic anemia, or MAHA, and subsequent systemic ischemia. TTP is a rare disease with an annual incidence of 2 to 6 new cases per million people. It is more frequent in females than males, with a ratio of 2 or 3 to 1, and it manifests at a median age of approximately 40 years. TTP is caused by a deficiency in the protein ADAMTS13, a metalloproteinase that cleaves and regulates the size of von Willebrand factor, or VWF multimers. When levels of ADAMTS13 drop, ultra-large VWF multimers accumulate, leading to uncontrolled platelet-rich thrombus formation in small blood vessels. There are two main forms of TTP. Congenital TTP, or cTTP, is due to inherited mutations in the ADAMTS13 gene. Acquired or immune-mediated TTP, in short ITTP, accounts for more than 95% of cases and is caused by autoantibodies against ADAMTS13, which develop with a yet unknown cause. TTP can be triggered by conditions that increase VWF levels, such as pregnancy and inflammation due to surgery, infection, autoimmune disorders, or cancer. Acute episodes of TTP are usually rapidly progressing and often fatal if not diagnosed and treated immediately. Risk factors for mortality include age greater than 60 years, severe involvement of the central nervous system, lactase dehydrogenase, or LDH, levels greater than 10 times the upper limit of normal, and cardiac troponin levels greater than 0.25 micrograms per liter at presentation. Despite the availability of treatment for TTP, a number of unmet needs remain in terms of diagnosis and management. Acute episodes still result in 10 to 20% fatalities, and the disease course may be complicated by exacerbations which occur in up to 50% of cases, and refractoriness to standard treatment. Furthermore, major thrombotic complications that may occur during the first 3 to 5 days of acute events often have long-term consequences for health and quality of life. Recurrence experienced by 30 to 40% of patients is also a major concern.
Applications in medicine. Caplacizumab, an anti-von Willebrand factor humanized single variable domain immunoglobulin nanobody, inhibits the interaction between ultra-large von Willebrand factor multimers and platelets.
Acquired thrombotic thrombocytopenic purpura is a potentially life-threatening condition caused by an autoantibody to ADAMTS13. Reduced activity of ADAMTS13 leads to the accumulation of ultra-large von Willebrand factor molecules that can bind to platelets and induce aggregation, leading to systemic microvascular thrombosis. This in turn can cause severe thrombocytopenia, hemolytic anemia, and multi-organ failure. Caplacizumab is a nanobody, a single monomeric variable antibody domain that targets von Willebrand factor and blocks interactions with the GP1b receptors on platelets. Investigators conducted a Phase 2 single-blind study at 56 sites worldwide, randomizing 75 patients with acquired thrombotic thrombocytopenic purpura to receive either caplacizumab or placebo, in addition to standard of care treatment, daily plasma exchange, and immunosuppressive therapy. As compared with standard treatment plus placebo, standard treatment plus caplacizumab reduced the median time to recovery of platelet counts. Exacerbation of thrombocytopenia within 30 days after the end of daily plasma exchange was also less frequent with caplacizumab, but bleeding-related adverse events were more frequent in the caplacizumab group. Thus, caplacizumab induced a significantly faster resolution of acute acquired thrombotic thrombocytopenic purpura than did placebo. Full study results are available at nejm.org.
We've presented a trial which is a randomised trial looking at a new type of therapy called a nanobody. This is a very important molecule which can act specifically and be manipulated to prevent the platelet VWF binding. It was a randomised trial where patients received standard therapy and they either received drug or placebo before plasma exchange was started, and this was continued following plasma exchange on a daily basis for up to 30 days after achieving remission. And remission is defined by normalisation of the platelet count.
What we achieved actually was the number of the days for the normalization of the platelet was significantly lower for those patients that they were treated with caplacizumab. And as a secondary outcome was extremely interesting that because we could see that for 30 days that patients were treated with caplacizumab, they were protected to have exacerbation. There was few mucosal type of bleeding, but in none of the patients there was a need to use the concentrate to solve the problem of the bleeding. So I would say all over, the drug could increase minimally the mucosal type of bleeding, but not significant bleeding episode that could create a clinical alteration for the patient to prevent the use of this drug.
The importance of this paper is twofold. Firstly, it's the method of action of the compound, which is really quite unique. It's not associated with significant side effects. It doesn't appear to be immunogenic. The second important, and probably the most important reason for this trial is that we have always been stuck in the acute scenario of trying to achieve a rapid increase in the platelet count, which in itself is associated with a better outcome for patients, and that's exactly what's been demonstrated in this paper.
I think it could have two significant impacts. One is sort of decreasing the dependence on plasma exchange. Despite the advances in immune suppressive therapy, better plasma exchange, better supportive care, the 10 to 15% acute mortality in acquired TTP in an acute episode has not been impacted. And I think this has the potential to do that.
For me, the most important thing was, even if I'm working and I'm trying with the PECs to remove the platelet, I'm trying to do the best that I can do at the immune system with the immunosuppressive treatment, but the disease is too fast and I'm not able to achieve the result I want. With this drug, I can control the symptom. I can detach the platelet from ultra-large von Willebrand factor and not having the consequence damage of this microthrombosis and giving me time to move on with the other type of the facility I have. That is fantastic. I mean, this is, I think, the reason why this paper is very much appreciated for the physician and also mainly for the patient, I would say.
Pros and cons. Pros. Its bioavailability is high, 90%, reaching a peak plasma concentration of 348 to 528 nanogram per milliliters in the first 6 or 7 hours. Cons. Multiple side effects like epistaxis, headache, subarachnoid and retinal hemorrhage, metrorrhagia, and allergic dermatitis.
Acquired thrombotic thrombocytopenic purpura, or TTP, is an immune-mediated disorder caused by deficiency of ADAMTS13. ADAMTS13 processes large von Willebrand factor molecules into smaller functional units. Lack of ADAMTS13 leads to unrestrained von Willebrand factor platelet adhesion, causing microthrombosis, thrombocytopenia, and hemolytic anemia. Caplacizumab is a humanized, bivalent, variable domain-only immunoglobulin fragment that inhibits von Willebrand factor platelet interaction and has been effective at reversing the thrombosis and hemolysis and correcting thrombocytopenia in Phase 2 human studies. In this multi-center randomized placebo-controlled trial, 145 patients with a diagnosis of TTP based on clinical presentation who had had one previous plasma exchange treatment were randomized to 10 milligrams of caplacizumab daily or placebo, in addition to daily plasma exchange and glucocorticoids. The primary endpoint was the time to platelet count normalization. Patients who received caplacizumab achieved faster platelet count normalization than those who received placebo. At any given time, caplacizumab-treated patients were 1.55 times as likely to have a normal platelet count. The composite secondary outcome of TTP-related death, TTP recurrence, or major thromboembolic event occurred in significantly fewer patients who received caplacizumab. A greater proportion of patients who received caplacizumab had bleeding-related adverse effects, most of which resolved without intervention. The authors conclude that caplacizumab reduced the time to platelet count normalization and the incidence of a composite of TTP-related death, TTP recurrence, or major thromboembolic events. Full trial results are available at nejm.org.
Issue applied in Ecuador. In Ecuador, it's not already distributed The clinical use of Caplacizumab for acquired TTP, but this type of treatment will upgrade the clinical potential of our country in order to handle in a better way these cases. And finally, by conclusion, Caplacizumab induced a faster resolution of the acute TTP episode than placebo. The platelets protective effect of Caplacizumab was maintained during the treatment period, and Caplacizumab was associated with an increased tendency towards bleeding as compared with the placebo. Thank you very much.